The non-occlusive form of the acute severe mesenteric ischemia is called the subacute severe mesenteric ischemia. It's actually non-thrombotic or embolic. It's just a decrease in the blood flow in the vessels, and it's less common than the sudden acute severe mesenteric artery ischemia. And that's why it has an insidious form of presentation, usually without pain and non-specific GI symptoms. The diagnosis is again through the CT angiogram, and it would show what's called a string of sausages on the CT angio. Treatment is usually towards the etiology through optimization of the cardiac status, along with the supportive measures. Now the chronic mesenteric ischemia that affects the severe mesenteric artery, usually it's due to a long-standing vascular insufficiency, aging, dyslipidemia, hypertension, smoking, polyarthritis nodosa, and diabetes that is long-standing, and as you know, it leads to macrovascular disease. The patient usually complain of the cetophobia, which is the fear of food, or what we call it intestinal angina. Usually the abdominal pain increases with eating, and usually it's 30 minutes postprandial and lasts for 1 to 3 hours. And with time, pain persists and makes the patient avoid food and lose weight. Again, the diagnosis is the same for all forms of the severe mesenteric artery ischemic forms, which is CT angiogram. The treatment is through the angioplasty along plus or minus stenting versus surgical revascularization. Alright, now let's look at this image here. This is the esophagus, aorta. This is the celiac trunk. And while the celiac trunk is taken off from the aorta, here is the, what we call it, the median arcuate ligament of the diaphragm. Alright. So we're going to discuss now what we call it the celiac artery compression syndrome, or the median arcuate ligament syndrome. It has another name also called Dunbar syndrome. This is a syndrome usually occurs in the young females. What happens is that the arcuate ligament poses an external compression on the celiac axis, both the nerves and the celiac artery. It might also lead to severe mesenteric artery syndrome. The pain here is actually neuronal rather than vascular, so it's not an ischemic phenomenon, it's a neuronal phenomenon, because it's only one vessel usually involved and there's a well-developed collaterals. The symptoms leads to a postprandial upper abdominal pain, which is actually secondary to increase of the blood flow after the feeding status through the celiac artery. And that pain leads that the patients also fear food, so they lose weight and they start complaining of epigastric pain in the area. One characteristic feature of the celiac artery compression syndrome is the emergence of the systolic sound or bruit. Diagnosis here again is through a CT angiogram or Doppler. There will be no ischemic bowel features actually. What you're gonna see is the this concavity defect at the superior aspect of the celiac artery while it takes off from the aorta. And you might also see the emergence of collaterals. Again, here is a look at the image. Here is from lateral view. This is the median arcuate ligament, and it's impinging on the celiac trunk while it takes off from the aorta. The management usually surgical to release the celiac arterial compression or arterial reconstruction. Alright, now we will talk about the splanchnic artery aneurysms. We have three arteries here, the mesenteric, splenic artery, and the hepatic artery. Actually, the mesenteric and the splanchnic, usually the etiology is atherosclerotic disease, while the splanchnic and the splenic and the hepatic usually is traumatic etiology, like liver biopsy. Common etiologies here are fibrodysplasia, portal hypertension, pregnancy, and what's important here is the pancreatitis, bear that in mind, and pseudocyst, and other types of vasculitis like the Ehlers-Danlos syndrome and pseudoxanthoma elasticum. Symptoms-wise, there might be a pain, GI bleed, intraperitoneal bleed, and with the hepatic artery there might be jaundice and pruee, along with hemophilia. One thing regarding the splenic artery aneurysm, if it ruptures into the pancreatic duct, it will give rise to the hemosuccus pancreaticus, and that is a form of a GI bleeding, of course. Diagnosis here is through the CT angiogram. Management here, it's mostly depend on the symptoms or the size. If the patient is symptomatic, any size of these aneurysms, it will require treatment. Size-wise, the hepatic artery aneurysm, if it's more than 1 centimeter, you go ahead and send the patient for surgery or embolization. The splenic and the mesenteric arteries, the cutoff size here is 2 centimeters. That will require the surgery or embolization. The only one thing here, if the patient is pregnant at any size during the pregnancy, you need to embolize those patients, regardless of the size. The last thing we're going to talk about is this syndrome full of German names. It's called Haida Syndrome, and this is the other German name is von Willebrand factor. Actually, it's a form of GI bleeding that occurs in patients who have aortic stenosis, along with multiple AVMs. The pathophysiology of this phenomena is that the aortic stenosis leads to consumption of the von Willebrand factor, and leading to bleeding from the AVMs. Symptoms, as we said, it's a combination of aortic stenosis and upper GI bleeding. Diagnosis here depends on the patient presentation. If the patient is actively bleeding, you would send him for an angiography. Otherwise, if the patient is not actively bleeding, you will treat him like any case of the GI bleeding, so you will need to run an EGD and colonoscopy on that patient. The first line of treatment of Haida syndrome is aortic valve replacement. It's the best option here, and it's found to improve the bleeding from the AVMs. If there's anemia and a GI bleeding, you still go and do the EGD and colonoscopy, as we said. Estrogen has a minimal role here, and they consider the second line of treatment.